moment. So since the time of James Mackenzie, we've had a revolution in therapeutics, which means we now have safe and effective treatments for almost all of the significant conditions that we commonly manage in general practice. In this lecture, I'm going to celebrate this and highlight how we can make best use of medicines for the benefit of patients, drawing upon some of the research and educational interventions that I've been fortunate to be involved with. To start with, however, I'm going to explain the relevance of this lecture to James Mackenzie's life and work, to highlight the advances in therapeutics that place GPs at the forefront of reducing morbidity and mortality, but also to highlight a number of media and public and professional concerns about medicines, which I think we need to consider, before then going on to describe a number of ways in which we can help ensure patients get maximum benefit from their medicines, a prescription for safe and effective care. So James Mackenzie was born in Picton Hill in Scone in Scotland in 1853, son of a farmer. He left school at the age of 14 and was apprenticed to a chemist. In 1873, he decided to do medicine and studied at the University of Edinburgh, qualifying in 1878. He was a GP in Burnley for more than a quarter of a century, developing a special interest in cardiology, and he was knighted in 1915. His legacy laid the foundations for academic general practice and indeed a lot of the developments that led to the formation of the college, and he continues to have an influence even today. His daughter, Dorothy, bequeathed much of the family fortune for the creation of academic posts in Mackenzie's name, most notably the first chair of academic general practice at Edinburgh University in 1963, a second chair at Aberdeen University in 1970, and also pump priming for the Department of General Practice in the Postgraduate Medical School at the University of Exeter. So what's the relevance of this lecture to the work of James Mackenzie? Well, firstly, I'm going to focus parts of my presentation on cardiovascular disease, which, as I've mentioned, was his area of special interest. And secondly, he demonstrated the rigour needed to establish the safety and effectiveness of medicines, and also the rigour needed to conduct high-quality research. And this is highly relevant to what I'll be discussing in the lecture. So let's hear a bit more about his work. Mackenzie was a pioneer in the study of cardiac arrhythmias. He developed something called the polygraph, which was an instrument that could simultaneously record tracings of the radial pulse, the apex beat, carotid, venous, or liver pulse, or respiratory movements. And through this, Mackenzie was able to describe the functioning of the heart in health and disease. He published a series of 5 papers in the BMJ in 1905, which I think was an incredible achievement. And in one of those, he described the action of digitalis on the heart. Indeed, he was responsible for reviving the rational and practical use of digitalis, particularly in patients with atrial fibrillation with fast ventricular response. So Mackenzie's work was highly relevant to the safe and effective use of medicines. Another point to make is that Mackenzie recognised the importance of the expert generalist in managing patients. And indeed, here's a quote for him. "I fear the day may come when a heart specialist will no longer be a physician looking at the body as a whole, but one with more and more complicated instruments looking in a narrow and restricted area of the body. That was never my idea." So what about the relevance of this lecture to the life of James Mackenzie? Well, as I said, Mackenzie focused his working life on understanding the functioning of the heart in health and disease, but there were few effective treatments available. And Mackenzie himself developed angina. Indeed, he probably had a myocardial infarction in his 40s. And it's clear that the later part of his life was significantly affected by disabling chest pain, and trinitrin was the only thing available for symptomatic relief. Had he lived today, there would have been a very good chance of a rapid response to his initial heart attack with effective secondary prevention that could have left him symptom-free and potentially added many years to his life. But not only that, his daughter Dorothy, who I've already mentioned, had polio as a child and lived her life with this disability. And then Mackenzie's older daughter, Jean, developed frontal sinusitis, then meningitis, and died in 1909 as a teenager. So the outlook for the whole family would have been very different with access to modern medicines and vaccines. So we now have effective and relatively safe treatments for most of the serious conditions that we encounter in general practice, and for many minor conditions. And as a result, general practice is now one of the best career choices for doctors who want to help patients live long and healthy lives. For example, as GPs, we are now responsible for the vast majority of the long-term therapeutic management of patients with diabetes, hypertension, and a range of cardiovascular diseases. And this has changed considerably even in the 25 years that I've been in general practice. Back in the early 1990s, hospitals did most of the follow-up for patients with diabetes. And even with hypertension, it was not uncommon to ask advice from secondary care. Patients with conditions like coronary heart disease and angina were also commonly followed up in hospital outpatient clinic. Nowadays, we're responsible for the long-term management of almost all of these patients and have demonstrated that we can provide high-quality care. Now, for quite some time, I've wanted to try and quantify the benefits of high-quality, evidence-based prescribing on morbidity and mortality from cardiovascular disease in general practice, just to confirm what sort of level of impact we can have as GPs. And so for the purposes of this lecture, I've looked at this in some detail, and I'm going to give some estimates of the benefits we can achieve, taking into account the prevalence of disease based on quality and outcomes framework data or Q research data, number needed to treat from randomized trials and systematic reviews, and then putting this to describe the potential benefits over a 5-year period in a practice with a list size of, say, 10,000 patients. Before showing you this, you need to be aware that we can't necessarily extrapolate the results of randomized trial to the populations that we see in general practice. The findings are based on treatment versus no treatment or placebo, and findings can differ between depending on which study you use for calculating numbers needed to treat. And there may, of course, be an overlap in life stages between different conditions such as hypertension and coronary heart disease. And indeed, some of the therapeutic interventions for these patients will be from outside general practice. But nevertheless, if we look at controlling hypertension, so this is taking patients aged 60 years and older with hypertension. The prevalence of hypertension in the over 60s is 46%, according to Q research. So in a practice with 10,000 patients, you're going to have about 1,300 with hypertension. The number needed to treat to prevent death over 5 years is 75. And so you can expect from high-quality care of patients with hypertension, bringing that blood pressure down to normal, we could prevent 18 deaths over a 5-year period in a practice with 10,000 patients. In terms of statins and coronary heart disease, we have a prevalence in QOF of 3.4%, which means 340 patients in our practice of 10,000. The number needed to treat to prevent a death over 5 years is 85. So that means we could expect with high quality care, a number of deaths prevented over 5 years being 4. Moving down, looking at prevention of stroke over 5 years, a number needed to treat there is 67. Preventing 5 strokes over 5 years. And then in terms of preventing MI, then a number of MIs prevented, potentially 3. In terms of atrial fibrillation in patients aged 75 years and older treated with warfarin, these are potentially an underestimate on this slide because I've simply taken patients aged 75 years and older, of which the prevalence is about 15%, but I've not factored in the fact that nearly half of them will have hypertension and many more will have heart failure and other conditions. But we expect to have about 140 of these patients in a practice with 10,000 patients. Number needed to treat to prevent death over 5 years is 54. So we can expect to prevent 2 or 3 deaths over 5 years. And this is the final example, heart failure. Prevalence in QOF of 0.7%, so we can expect 70 patients in our practice. Number needed to treat to prevent death over 5 years based on average patients with mild to moderate heart failure being 20. And so we'd expect to prevent 3 or 4 deaths over a 5-year period. So there are many caveats, as I said, to the application of these number needed to treat data to general practice populations. But nevertheless, from the previous examples alone, A practice with a population of 10,000 may be able to prevent deaths in up to 30 patients over a 5-year period from high-quality care. And Bradford's Healthy Hearts is a great example of what can be achieved. And this was highlighted at the recent RCGP annual conference. Launched in October 2014, 41 general practices shared their clinical data and identified nearly 7,000 patients with uncontrolled cholesterol that could be improved by changing their medication, and nearly 5,000 patients with a 10-year risk of cardiovascular disease above 20% who were not on a statin at all. They did 6,000 statin switches by batch switching medication. 4,000 were started on statins. They helped direct GPs to action in stroke prevention for patients with atrial fibrillation and encouraged self-titration of antihypertensive medication based on the Tasmin study. And they've already demonstrated in Bradford fewer cardiovascular events and won the BMJ Clinical Leadership Awards this year. In addition to cardiovascular disease, there are, of course, a whole range of conditions where we have effective treatments. And just to give some examples, we obviously have highly effective treatments now for the management of asthma. Despite concerns about antimicrobial resistance, we still have effective treatments for a range of bacterial infections. We have effective treatments for acute pain, and although chronic pain remains a challenge, but in palliative care, it's incredible how well we can manage symptoms so that the vast majority of patients who want to die at home can die at home and in comfort. And we have effective treatments for a range of minor conditions that can help improve patient quality of life. It's difficult, however, to celebrate the impact that we can have through effective use of medicines in general practice because there's so much negativity around concerning the use of medicines. And so before I go on to talk about how we can make best use of medicines for our patients, I just want to address this because there's a major issue of trust that we need to be aware of when talking to patients about medicines. Here are a series of headlines concerning statins. On this slide, we see what we get in the early stages of the launch of new medicines with overwhelmingly positive stories. This soon followed, however, by increasingly negative comments. So the one on the left, statins can be a risk to health, but drug is still a lifesaver, so it's still on balance positive. But then we get doctors ban on statins, medics at war over drug advice that we should be prescribing statins more. And then, new statins bombshell. Medical experts angry that doctors will be paid to prescribe the controversial drugs. Health chief slams statins. Millions face terrible side effects as drug is planned for 1 in 4. And the thing is, we know from recent BMJ study that these do put patients off from taking potentially life-saving medicines. So these headlines can actually be associated with patients dying effectively from not taking their medicine and stopping them. And even when high-quality evidence is produced, there are still detractors. So let's just go back and look at that again. This is from the recent Lancet paper from Rory Collins and colleagues, confirming the life-saving benefits of statins while also providing some reassurance about risk. And this particular slide is from a meta-analysis, and this picks up on the point that they've raised, that large-scale evidence from randomized trials show that statin therapy reduces the risk of major vascular events by about a quarter for each millimole per litre reduction in LDL cholesterol during each year after the first that it continues to be taken. And the only serious adverse events that have been shown to be caused by the long-term statin therapy are myopathy, which we're well aware of, new onset diabetes, and probably hemorrhagic stroke. However, any adverse impact of these side effects on major vascular events has already been taken into account in the estimates of absolute benefits. And also, any increase in hemorrhagic stroke is very small compared with thrombotic strokes that are prevented by statins. But despite that evidence, respective colleagues still have serious concerns. You will have probably picked up there's been a great battle going on between the BMJ and the Lancet over this, and Trish Greenhow is clearly siding with the BMJ. I think it's a sign of our times that years of painstaking work by some of the top trialists and epidemiologists in the world can be dismissed in a tweet. From my perspective, I think the evidence is overwhelmingly in favour of statins, particularly in patients at high risk. This is not just from trials, but also from independent, large-scale observational studies that largely replicate the trial findings and are largely reassuring in terms of serious side effects. Nevertheless, it is in many ways understandable why there should be scepticism, because there's such a lack of trust in the pharmaceutical industry. And Ben Goldacre has highlighted this in his compelling book, Bad Pharma. One of the key concerns is what he calls missing data. This is, in other words, pharmaceutical companies are much more likely to publish positive results than negative ones by a factor of about 10 to 1. And so systematic reviewers do not have access to all the evidence. Also, there are what he calls bad trials, where, for example, the effectiveness or side effects of a new drug is compared to another drug that we know is not particularly effective or has a bad side effect profile. And furthermore, he raises concerns about regulators who may have access to all the relevant data from the pharmaceutical companies but do not share this with the wider scientific and health community. So we may be left in the dark for many years about unpublished evidence of serious effectiveness or serious side effects. There are also concerns about polypharmacy and the so-called medicalisation of society. And I'm sure that many of you will have had patients say, I take so many pills that if you shook me, I would rattle. And this is said as a joke, but it clearly displays an underlying concern, and many people would question whether it really can be right that patients need more than 10, more than 15, or even more than 20 medications. Nevertheless, as we stated in our King's Run report on the subject, and as featured here in the BMJ, could it be that polypharmacy is a necessary evil? I'll return to this later. We sometimes also have what I would say are own goals from our own profession. Here's an example from the recent BBC series on the doctor who gave up drugs. This is an infectious diseases doctor who parachutes himself into a sceptical general practice with the aim of getting patients off their medicines. You'll see here that in the programme he uses very emotional language. If I remember rightly, he's pictured on a high street market stall with masses of pills and calls out to passers-by things like, "We're selling pills with side effects guaranteed. Millions suffer side effects and thousands die. Gastric bleeding, sir." I've seen the programmes and it may be good TV, but I'm not sure it is helpful to patients. There's then concern about medication errors. These headlines are based on a study that I led, funded by the General Medical Council, to find out how common prescribing errors are in general practice, what the underlying causes are, and what can be done to prevent them. We found that the vast majority of prescribing was safe, but there were prescribing or monitoring errors in around 1 in 20 prescriptions, with serious errors in around 1 in 550 prescriptions. We launched our report at a press conference organised by the GMC, and inevitably we got headlines like these. Nevertheless, in the interviews that I did, I was able to talk about some of the positives of GP prescribing, and the publicity really galvanised support from the RCGP, Department of Health, and other organisations to do something about the problems we had highlighted. So this leads me on to my prescription for safe and effective care. Clearly, I can't cover the whole of therapeutics and the patient safety literature in the remainder of this lecture, but I would like to give you a flavour of some of the work I've been involved in over the last 15 years or so, expanding on some of the things that Maureen kindly said. First, I think it's worth highlighting the principles of rational prescribing. And this figure here is from Nick Barber, who's in the audience, and has had a major influence on thinking about this issue. I find this model really helpful as it shows the careful balances we have to consider when prescribing. Ideally, we would like to be prescribing drugs that are highly effective, completely safe, inexpensive, and universally acceptable to patients. In reality, we have to make trade-offs and taking into account the views of patients. So take statins, for example. As demonstrated already, these are effective at reducing LDL cholesterol and can save lives, particularly in patients at the highest risk of cardiovascular disease. Nevertheless, there are still trade-offs. So, for example, in a patient at very high risk, the benefits are likely to strongly outweigh any risks. And so I'd go to considerable effort to explain this to a patient in the hope they would agree to take the medication. In a lower risk scenario, and I had one on Monday with a 70-year-old woman with a 13% 10-year risk, I'd be more relaxed if, after giving explanation, they decided not to take the medication. Indeed, in that particular case, the lady was fit and well, she had a normal BMI, did regular exercise, and apart from her age, one reason for her risk being elevated was a family history of coronary heart disease. But as she pointed out, quite reasonably, these family members had been heavy smokers, whereas she had never smoked. Anyway, you won't be surprised to know that she decided not to take statins, and that's fine. But to give another example related to statins, nowadays, we almost always use atorvastatin rather than simvastatin because it's more effective at reducing LDL cholesterol, has a slightly better side effect profile, and can be taken any time during the day and is not currently significantly more expensive than simvastatin. But before atorvastatin came off patent a couple of years ago, it was at least 10 times more expensive than simvastatin. And in those days, we were strongly encouraged to prescribe simvastatin in prevalence in order to help manage the drug budget. And I think that was quite reasonable, given that the NHS has finite resources. A more recent concept is that of medicines optimization. This builds on the model that Nick developed, but you will see that the patient is clearly at the center here, and I think that's absolutely right. So moving on to safety. Back in the late 1990s, I was convinced that GP computer systems could help us to prescribe more safely, but I was also aware that there were deficiencies. With funding from the National Patient Safety Agency and NHS Connecting Health, and with major input from Maureen Baker and Nick Barber, I led and collaborated on a number of studies over the following 10 years aimed at realising the potential for GP computer systems to improve patient safety. So we did a large-scale questionnaire study, and overall GPs were positive about the potential for GP computer systems to improve the safety of prescribing. And they thought that having alerts for allergies, drug interactions, contraindications was particularly important. They also thought it should be more difficult to override critical alerts, and there needed to be better systems for recall of patients for monitoring. In addition, however, nearly a quarter of GPs admitted to overriding computerized alerts without properly checking them. Many were not fully aware of the safety features on their computer systems. A third thought that they had contraindication alerts on the system when in fact they did not, and only a minority had training on the use of the safety features on their computer systems. And so we assessed the safety features of commonly used GP computer systems, and the findings were published in the BMJ. We found that there are a lot of good features, but we detected many problems. This slide shows an example relevant to a case where a young GP was accused of medical negligent manslaughter because he inadvertently selected high-strength morphine sulfate solution from a drop-down menu. Bizarrely, on typing the brand name Oromorph into the computer, the first product presented to the doctor was generic morphine sulfate concentrated oral solution, which, as you know, is 10 times the strength of normal morphine sulfate solution. Why did this product come first on the drop-down menu? Because alphabetically, morphine sulfate concentrated oral solution comes before morphine sulfate solution in the alphabet. And clearly, if computer systems are designed in this sort of way, it's only a matter of time before a GP, like in this case, inadvertently selects a first preparation on the drop-down menu, and a patient may die as a result of this. Electronic prescribing can improve safety in many ways, but unless it is well designed, it can introduce new and sometimes serious risks. Some of the other problems we detected were lack of alerts in relation to contraindications, which I've already mentioned. Spurious alerts, where we get alerts for things that are really not important at all. Failures of drug allergy warnings we found in some cases, where GPs had actually recorded that a patient had got an allergy, but it didn't fire the warning when you came to try and prescribe the drug again. Risks of prescribing with drugs with similar names due to errors using drop-down menus. Lack of warning for methotrexate, which, as you know, is normally prescribed on a weekly basis in general practice, but there used to be problems with it accidentally being prescribed daily, and as you'll be aware now, it's almost impossible to do that because of the way systems we have now. And also the fact that it's easy to override most alerts, and indeed it still is, apart from a few examples like methotrexate. So we also did a systematic review of studies that looked at the effectiveness of computerized alerts and prompts, and we showed that there was modest evidence that these could improve patient safety. But also, as I've illustrated above, If systems are not well designed or are poorly implemented, they're likely to be risks to patients. From interviews with key stakeholders and a consensus study, we identified the improvements that were needed in GP computer systems and developed a design specification to help guide the next generation of systems. Maureen took this forward in her NHS IT roles, and while still not perfect, our modern systems now have many of the features we were calling for 10 years ago. So, in terms of electronic prescribing, my prescription for safe care involves encouraging computer system suppliers to make the best use of clinical decision support technologies to provide us with high-quality information at the point of decision-making, to help us give appropriate dose instructions, and to provide context-specific dose guidance when taking account of patient factors such as their age and renal function, to alert us to the most common and important examples of hazardous prescribing, but to avoid over-alerting, and alerting to the need for blood test monitoring for certain high-risk drugs. And then to make sure that they design systems to help us make the right choices and minimize the risks that there may be in electronic prescribing. Now, much of the research that I've done has involved investigating the role of pharmacists in helping GPs to improve the safety of their prescribing. Community pharmacists have a long history of helping to ensure the safe use of medicines in primary care. And pharmacists' roles in general practice have developed over the last 15 years. For example, with the role taken on by pharmacists attached to primary care organisations such as CCGs. As part of the NHS Forward View, practice-based pharmacist roles are now being expanded with a £112 million investment for 1,500 new jobs. And this has all been helped along by the strong collaboration between the Royal College of GPs and the Royal Pharmaceutical Society. And here you'll see a picture of Nigel Mathers illustrating this. Now, there's potential for pharmacists to become even more involved in a wide range of prescribing initiatives, including medicines review for higher risk patients. And one example of this is the PINSA trial. In this study, we designed and evaluated a pharmacist-led, IT-based intervention whereby we identified patients at risk from their medicines through searches of the GP computer system, and then had a pharmacist work closely with the practices to correct any problems identified and try to improve safety systems to prevent future problems. This was a cluster randomized trial in 72 general practices, and the results were published in The Lancet in 2012, showing that at 6-month follow-up, patients in the PINSA group had significantly fewer prescribing errors than those in the control group, that there was evidence that the intervention was cost-effective, and that it could be rolled out across the NHS at low cost to reduce medication errors. The PINSA intervention was recommended by NICE in its medicines optimisation clinical guideline. Now, the computer queries we developed for the PINSA trial have now been made available on the Primus website, and they've been downloaded by over 2,000 general practices across 196 clinical commissioning groups. So that means 28% of the practices in the country have used these, and 94% of clinical commissioning groups have at least one practice that has used them. In addition, with funding from the Health Foundation and East Midlands Academic Health Sciences Network, we're rolling out the PINSA interventions in real detail to over 300 general practices in the East Midlands. And we've just received an NIHR programme grant to evaluate the effectiveness of this rollout on potential reduction in serious harm outcomes, including hospital admissions and deaths. Now, the interface between primary and secondary care is potentially a very dangerous place for patients. And we really do need to mind the gap and ensure that we have effective methods of communication so that patients don't suffer as a result of lack of accurate and timely information transfer. So it's essential for us to provide accurate information when patients are admitted to hospital, or to make sure that in the background the summary care record is updated so that hospitals have access to that information. But then for hospitals to then provide us with accurate and timely information when patients are discharged back to us. But then we also need to have robust systems in place for updating our records to make sure that the prescriptions are updated following that discharge. And to give a practical example of this, in the healthcare community in Nottingham, we've worked really hard to try and improve things in recent years. So a few years ago, if I was called to see a patient on a Monday who'd been discharged from hospital over the weekend, it often felt like I was flying blind, because I had little or no information on why the patient had been in hospital or what changes had been made to their medication. From numerous frustrating experiences, it was usually close to impossible to get any useful information by phoning the hospital, and sometimes I had to send patients back into hospital because I just couldn't work out what was going on. Now, primary and secondary care work well together to design better ways of communication, including an electronic discharge document that clearly states the reason for the admission, any important investigations undertaken, and any changes to medication, including the reason why. So nowadays, if I see a patient on a Monday who's been discharged from hospital over the weekend, the electronic discharge document is almost always available, and this has made a massive difference in helping me to manage the patient safely and effectively. In fact, we did a project with medical students in Nottingham looking at the effects of the introduction of this new electronic discharge communication system, and we showed significant improvements in the completeness and timeliness of the information provided to GPs. So on this graph, the dotted line is where the point at which the new discharge summary was switched on. And you can see that we've gone up from a 60% completeness rate for clinically important information in the discharge summary to over 75%. Now, when we interviewed GPs as part of our GMC-funded study on prescribing errors, one of the important things they said was that they'd had relatively little education on therapeutics and safe prescribing, either as undergraduates or postgraduates. And having identified this, we worked hard with the RCGP and other organisations over recent years to address this. Firstly, we developed e-learning materials, and I'll mention these on the next slide. Secondly, we've worked with the RCGP to ensure there's a greater emphasis on prescribing in the RCGP curriculum and examination. We produced a series of articles on safe prescribing for GP associates in training in 2013 and developed a project which we call 100 Prescription Projects, which I'll mention again in a minute, to give feedback to GP associates in training on their prescribing. Thirdly, we developed a patient safety toolkit to provide GPs with a range of tools for improving safety in their practices. The e-learning package we developed was launched nationally on the RCGP e-learning platform in January 2014 and is currently open to all healthcare professionals. It consists of 5 e-learning lessons packed with practical examples and covers appropriate drug selection, building on the sort of things I was discussing earlier in relation to Nick's work, avoiding prescribing errors, choosing the right dose, getting the dose instructions right, and effective medication reviews. The site's been accessed by more than 2,000 individual users, and more than 500 have left responses to a detailed feedback questionnaire. 98% of users who responded to the survey agreed that the e-learning module had increased their knowledge of prescribing. 98% also agreed that the e-learning had been a useful part of their continuing professional development. And we also demonstrated significant improvement in knowledge based on pre- and post-course assessment questions. The idea for the 100 Prescriptions project also came out of the GMC study, and it involves a pharmacist's review of 100 consecutive prescriptions from a GP associate in training. A detailed report is then produced to identify examples of good prescribing and areas for improvement, and this is then discussed with the associate in training and the trainer. And so far, it looks like a promising intervention. It identifies patterns of prescribing that clearly need to be addressed in order to improve effectiveness and safety, and feedback from AITs and GP trainers have been very positive so far. We're now working with the Centre for Postgraduate Pharmacy Education and Health Education England to roll out and evaluate this initiative, and this may well become a standard part of GP training in years to come. The Patient Safety Toolkit is something we developed with funding from the NIHR School for Primary Care Research, and last year it was taken on as an RCGP clinical priority programme and has been available on the RCGP website for over a year now. It consists of a range of tools to help GPs address safety concerns in their practices, including a number of prescribing-related tools. We've had over 5,000 hits on the website, and the toolkit was shortlisted for the 2016 Patient Safety Awards and identified as one of the top 10 achievements at the NIHR School for Primary Care Research. So what about the thorny issue of polypharmacy? I had the privilege of being part of a small team that was asked to produce a report for the King's Fund on this issue, and we concluded that while polypharmacy is a problem for many patients, in some cases it is appropriate, or what we might call a necessary evil. So in terms of addressing polypharmacy, I think one of the key things to say is the evidence base for it is poor. There have been very, very few trials that actually involve people with more than one condition, involve patients with more than one medicine, and certainly not the sort of patients we see with 5 or 6 or 7 conditions and up to 20 or more medications. But nevertheless, we're faced with really difficult decisions, when often all we have to go on is evidence-based guidelines for single conditions. In many cases, however, it does seem appropriate to prescribe multiple medications based on existing single condition evidence, provided that the benefits are likely to outweigh the risks, the patient is willing and able to take the medication, they can cope with the medication burden, and that therapeutic cascade, whereby you can end up prescribing more and more drugs to patients to treat the side effects of the things that you've already given them, if we can avoid that, if at all possible. But there are, however, circumstances where the evidence is not strong enough to justify continued treatment, and that's particularly, I think, as patients get towards the later stages of their lives, and actually where their priorities change, and actually having another 5 or 10 or 20 years of life is not their number one priority, and it may actually having better pain relief or better quality of life. And here we need help in terms of, well, how do we decide, what to do with this list of medication? What is it that we could discuss with the patient and see that we could withdraw? And this is where NHS Scotland polypharmacy guidance is really, really helpful. If you've not seen it, I'd urge you to have a look at it. And one of the things I find particularly helpful in there is it actually lists numbers needed to treat and numbers needed to harm for a wide range of conditions. And so, for example, whatever the condition might be, it might be hypertension, it might be other things. But if you've got a number needed to treat of 300 to prevent a stroke or a fracture or whatever it might be, in someone who's probably not likely to live more than 2 or 3 years, that might be one of the drugs that you would look at and say, do we really need to be prescribing this? But in all of this, in all the things I've been talking about, the most important thing we need to do is work in partnership with patients. At the end of the day, it's the patient's choice as to whether they take medicines, and I'm a strong believer in patient autonomy. But nevertheless, within the limited time we have in GP consultations, I think it's important that we find the time to listen to patients so that we know their views on medicines and we understand their experiences of medicine taking. Working with other healthcare professionals, such as pharmacists, we also need to provide succinct information to help patients make decisions on whether or not to take the medicines we suggest for them. Explaining things like, what does the medicine do? Why is it important to take the medicine? Are there any other treatment options? As you know, patients are often very keen to consider non-pharmaceutical options. When and how should they take the medicine? How long should they take it for? And what should they be aware of when taking the medicine? For example, what are the risks? What are the main side effects? What do they need to do if they don't feel well when taking it? And where can they get more information? Clearly, we don't have time to cover all of this in a 10-minute consultation, and this is where coordination with community pharmacy is important. The new medicine service is an example of this, whereby patients do get this sort of detailed input for certain classes of drugs, such as antihypertensives and asthma medications. And for patients who do wish to take their medicines, particularly patients on multiple medicines, we may need to help them with strategies to ensure that they do take their medicines as prescribed wherever possible. Yet again, this is something where coordination between general practice and community pharmacy can be very helpful. Now, one of the key issues in working in partnership with patients is the building and maintaining of trust. And this is a potential challenge, given the points that I've made earlier, where there is what Honora and Neil described as a crisis of trust in the context of what is called the risk society, whereby the world has become so complex that people fear a range of hidden and incomprehensible risks. And this is particularly relevant in relation to medicine taking. Nevertheless, trust in general practitioners remains high. For example, 84% of the public trust family doctors to tell the truth. But how do we maintain that trust? Well, what Honora O'Neill says is that trusting is not a matter of blind deference, but of placing or refusing trust with good judgment. And the fact is that we know that in our everyday lives, we have to place trust in other people, and we do make judgments about who to trust. And that means that despite all the negativity around medicines, GPs remain in a strong position to build and maintain trust with patients around medicine's use. So to summarise, advances in therapeutics mean that GPs are at the forefront of reducing morbidity and mortality. As I've described in relation to hypertension and cardiovascular disease alone, a well-organised modern general practice practising evidence-based medicine will save several patients' lives each year. And we have a vast range of effective medicines to treat a wide range of other conditions. This is something for us to celebrate, but we need to recognise there is a lack of trust around medicines, as I've described. But nevertheless, as I've just mentioned, we are in a strong position to counter this, given the trust that patients place in us and the patient-centred approach we take. As a clinical academic, I often think of mountain climbing as an analogy to the work that we do. As clinicians, we're able to see the problems that we face in delivering high-quality, effective care. And then as academics, we're able to describe these problems, investigate their causes, and develop and test solutions. Each project is like a very big mountain to be climbed, and it's important to do it with others, as you'll see on this slide. But once you get to the top, however, you'll see that there are further mountains in the distance. Now, James Mackenzie was a great example of a general practitioner who was passionate about understanding more about the workings of the heart with a view to solving the problems his patients presented with. He climbed mountains in this respect by pushing science forward with respect to understanding of cardiac arrhythmias and rediscovering the safe and effective use of digoxin. Many others have built upon his advances over the years, leading to the modern age where we now have effective and relatively safe drugs such as statins that can save thousands of lives. Now, I don't want to compare myself with James Mackenzie, but the journey I have been on over the last 10 to 15 or 15 to 20 years has taken me from trying to understand the nature and causes of prescribing safety problems in general practice to identifying solutions, some of which have had an influence on modern general practice in this country. There are still many more mountains to climb, and it may be for others to climb them. But I hope that elements of my prescription for safe and effective care will help in some way to ensure that patients get the maximum benefit from their medicines that we prescribe for them, while minimising the risk of harm. Thank you.